Hello and a very warm welcome to BW Healthcare Dialogue. With the rise of COVID cases and opportunistic infections, what we need to be aware is how challenges and life is getting exacerbated for those living with risk factors, particularly diabetes. As a country with one of the leading number of diabetics in the world, we need to understand how we can better manage and control diabetes while the cases continue to rise. We also are seeing an inflow of new technologies. Particularly in this conversation, we will be talking about time and range, a new method of monitoring one's diabetic levels. Joining me today is Dr. Ambrish Mithal, who specializes in diabetics and endocrinology. Very warm welcome to you, Dr. Mithal. Glad to have you today.
Thank you. Thank you for inviting me. Happy to be here.
So, Dr. Mithal, I want to first start off by understanding the current situation of COVID and how it impacts those with type 1 and type 2 diabetes. Is there any difference? What do you observe?
So, we need to first understand the relationship between diabetes and COVID because it's a two-way relationship. So, let's first look at what diabetes does to COVID. So, does someone with diabetes have a greater chance of contracting COVID? We are still a little unclear about that, whether people with diabetes have a greater chance of catching the infection. Maybe some of them do, we're not 100% sure. The data is not solid.
Right.
But if you talk of what happens to someone with diabetes when they contract COVID, that data is very solid. And that shows that people with diabetes, when they contract the infection, they have a greater risk of poorer outcomes. Which means they have a greater chance of hospitalization, greater chance of going to the ICU, requiring oxygen, requiring steroids, and even succumbing to the disease.
Right.
So this is the impact. Now, having said that, I'll just make a quick qualification. Not all diabetes falls in the same category. It's not all in the same basket. So it's not that every diabetic has those risks. But we will discuss as we go along who are the people who really are at greater risk. So that is one. The second question is, what does COVID do to diabetes? So what does the virus, the infection do to diabetes? Number one, any infection, any significant infection that we get, if it is enough to require hospitalization or, support or oxygen, will cause an aggravation increase in our blood glucose. There's no question about that. The second point is that when we have COVID infection, one of the life-saving drugs for COVID is glucocorticoid or steroids as we commonly call them. Now, steroids, which are very important sometimes in treating COVID, have a direct impact on blood sugar and send the blood sugar to astronomical levels, very high.
Right.
The third point there is that the virus itself, not just the stress produced by the virus, but the virus itself, it is thought may be affecting the pancreas and maybe actually resulting in a direct rise in blood sugar. So these are various things which are very important for us to understand the connection. Now, between type 1 and type 2, there is not that much difference in terms of their impact. The difference in impact, even in type 1 diabetes, initially people thought nothing will happen, but actually even in type 1 diabetes, there is a greater risk of the same serious consequences. We won't go into that again. Okay. But what is important here is to understand that people with type 1 diabetes are actually younger. They often have less comorbidities. They don't have all those complications very often as the person with type 2 diabetes has. So if they fall in that zone, then their risk may be a little less. Okay. On the other hand, if they're obese, because obesity is another big risk factor. So in type 2 diabetes, we know obesity and diabetes is a bad combination for COVID. In type 1 also, if someone becomes overweight, some kids are overweight and therefore you can get that. So I think it's important for us to understand. On the other hand, in type 1 diabetes, the challenge, like in type 2, but even more in type 1, is to control it well.
Okay.
Because when you give steroids and the same thing that I talked about, you understand that the fluctuations will be immense.
Right.
And those fluctuations have to be managed very, very skillfully by someone trained in that with adjustment of insulin, etc. So both are important, in other words, and both can cause adverse outcomes.
Right. So you answered this in part, but I want to understand how does the treatment plan in vary in particular? Now that there is also rise in Delta variant, so how do we understand for the common people? How is the treatment plan vary?
So let's start the treatment plan pre-COVID, COVID, and post-COVID. Now we're dealing with a lot of post-COVID.
Right.
Pre-COVID plan is to keep your blood glucose well controlled, and that will protect you from severe COVID. So it's very important that you monitor your glucose regularly, be in touch with your physician or doctor or specialist, whatever, and make sure that you're testing your blood glucose using glucose strips, or if depending on the kind of diabetes you have, if you have on multiple insulin injections using CGM technologies, we'll come to that later. But you have to keep your blood glucose in check.
Okay.
Period. Regardless of COVID or no COVID. Once you've done that, that means you've already protected yourself significantly from COVID. Obviously, you will do the other things that we ask people to do, masking, and especially masking, social distancing, avoiding crowding in indoor environments is very, very important. The offices, even hospitals, in the same room, a lot of people, if the mask goes off for a cup of coffee, there is a problem. Right? So those are there. But control of diabetes, control of blood pressure, control of all your parameters is very important pre-COVID. During COVID, the management changes because during COVID, sugars go sky high. Almost always we require insulin in moderate to severe COVID. And this insulin is temporary. So do not be scared of insulin use during COVID. You may require very often intensive monitoring, checking your sugar multiple times a day, or the use of a device that will monitor glucose constantly. We've done that very effectively in this COVID because this time around, a lot of patients we manage at home. So the patient empowerment concept is very strong in this. So I think we need to understand those. You can't just depend on the doctor because you're often not going to get hospitalized. You have to manage on your own.
Right.
So this is the main difference. So after COVID is over, many of us, naturally so, will be inclined to feel that everything is over. Now I'm fit and fine. But as you know, post-COVID recovery takes time. And I'm not going into all the aspects of post-COVID, but even glucose recovery following COVID can take time. It doesn't necessarily come back to baseline in a day or two. So you need few weeks, sometimes a few months to come back. So it's important to continue monitoring your glucose in the post-COVID period and be in touch with your doctor. I think that's important to realize that the sugar may not come back to normalcy very quickly.
Right. So firstly, maintaining all social distancing protocols and being constantly in touch with your physician and managing your glucose levels. Now, this brings me to understand the new technology on this front in terms of managing glucose levels. TIR, or time in range, wherein we understand the percentage of time a person spends in their blood sugar levels in the target range. So I want to understand better from you, doctor, how is this TIR method better than how we currently measure blood glucose levels?
Many years ago, Elliot Jocelyn, one of the fathers of diabetes treatment and research from Boston, said that the aim of diabetes treatment is to keep the blood glucose as close to normal as possible. Right. Now, how were we doing it? Once upon a time, we used to do it with venous blood glucose samples checked once a month, once in 2 weeks, like that, or once in 3 months, for all you know. Then it came round to glucose meters, as they're rightfully called, and they use, which we use all the time, pricks, and we monitor we chart the sugars, and the patient comes with a chart. There's a lot of advances in that. They can be directly uploaded to the server. The doctor can see it directly. That's the glucometer, which is smart glucose meters, which have really helped us a lot. That is the glucometer story. The third track in this, of course, is the measurement of HbA1c, which is a remarkable tool because it gives you last 3 months blood glucose average.
Right.
So you sort of get an idea of the mean blood glucose over the last 3 months. So we say typically a target of 7 is good for HbA1c, right? It could be higher or lower. That target will have to be variable based on the patient and what the doctor determines for their patient.
Right.
But then what happens is that if your sugars are fluctuating from 70 to 400, you may get an average of, let's say, 250.
Right.
240, right? And that may not be so bad. It's bad, but it may not show up so much. Or let's say you may even sometimes get an average which is actually looking pretty normal because the fluctuations are very wide. So HbA1c does not take into account the day-to-day fluctuations in blood glucose.
Right.
Therefore, the search for tools that will actually allow us, like an ECG or a Holter, like you do a Holter for the heart, where you record the ECG for 6 days, 7 days. Similarly, or you even do ambulatory blood pressure, you tie this machine that records your blood. So similarly, you want something for blood glucose. We wanted always something for blood glucose that will allow us to see all the fluctuations.
Right.
So this is where the ambulatory glucose monitoring has played a big role. And why, as you asked, why were these techniques not so important earlier? Why have they become important now? And there are multiple reasons. So the broad reasons are, number one, that they have become much easier now. They were much more complicated earlier, much more expensive. It has become easier to use. The patient can even attach the sensor themselves, So it is not a huge device kind of thing where technology has become very, very easy. So ease of use is one. The second is the recognition that, okay, you're saying it should be in normal range, but how do I care? Second is the recognition that if you're in that range of blood glucose, so you're getting like an ECG tracing. So if you're in that range band of blood glucose, your risk of getting long-term problems or even short-term problems is less. Right? So therefore, now what we are talking about is, okay, let's say a typical patient, we say 70 to 180 is your band, let's say, which means I want no glucose lower than 70 and no glucose higher than 180. So that's a dream that we would want, everything in that zone. And there will be some patients who do that. Early diabetes, treated well, good with diet and compliance. But generally, patients on insulin, etc., will find it difficult. So we would want at least 70% values in that zone.
Right.
You may want 80 for some patients, but so if you see a tracing of 24 hours and find you can mark a band, a gray band or something, and if you find that band is showing, that the tracing is showing bulk of the reading, 70% or more in that band, that is time spent in the range. So we want 70% of the time patient should be spending in range. That is TIR.
Okay.
So in addition to a good HbA1c, in addition to the good glucometer values that we expect, we add on and actually gradually displace the glucometer in patients where it's required. That with this TIR.
Okay.
Now, this technology is not just about TIR. TIR is very important, but it's also about overall management. The patient himself or herself can figure out, where am I going wrong? Because if you can see your blood glucose, you ate, one slice of bread and you found, oh my God, I never realized this. Doctor was saying that I never believed it. Now I know, my God, it's gone up so much because you can just swipe it and see where it goes. And it empowers the patient. Again, very relevant during COVID times, as I was telling you earlier, managing patients at home with these kind of values, these kind of medications was very difficult. And adding a continuous monitoring technology, empowering the patient to check their blood glucose 100 times a day without pricking is a huge thing. And so therefore, these devices are very, very useful. They are becoming simpler and simpler and more accurate. They help both the patient to self-titrate their medication, their insulin dose or food, and help us to get a good picture of what is really happening. So if you have an A1C and this continuous glucose monitoring or ambulatory glucose monitoring chart in front of you, you're very comfortable with treating a patient and confident that you are doing a good job with their glucose control.
Right. So now this actually brings me to the fact that a lot of countries, glucose monitoring manufacturers, globally, non-profit organizations, all of them are pushing for TIR to become a gold standard method, to make it universal. How far do you think we've come for that in India? Do you think we can see it becoming gold standard in the year to come? What's your opinion?
See, gold standard is a big phrase because you really are setting the bar with that. I think it'll take some time for us to reach there. But I do think as a very actually as an invaluable tool in assessing some kinds of patients, particularly those with longer standing diabetes, those on multiple drugs, those on multiple insulin shots, complex regimens. This is fantastic. For someone who's just managing on metformin or a gliptin metformin combination or one of those drugs that doesn't produce fluctuation, and the A1C is okay, it's probably not required. So except there are some patients who want it, who are very fussy and they want to see all their reading, that's all right. But for us, one of the main roles is this, that people on complex regimens. So it's not just about controlling glucose. It's not just about time in range. Time in range is also about avoiding low blood glucose. One of the challenges when you control diabetes with complex regimens involving tablets and multiple insulin shots is not only the excursions that go up, but also the plummeting, the dips that go below the range. And they can be very dangerous for certain kinds of patients.
Right.
They're not good for anybody, but they can be especially dangerous for people who have, high risk of cardiac events or who have kidney involvement or who have, older patients. There you've got to be very, very careful about what should be your target. And you really have to avoid hypoglycemia, even at the cost of a little bit higher sugar. So there are a lot of things that these devices do. In terms of their usage, in terms of guidelines, they've already appeared in the international guidelines. Right. So, and that's as late as just a couple of years. It is definitely something that has changed from earlier years. That's very important. I do expect at some point they will make their way into the Indian proper guidelines. At the moment, the guidelines for the use of TIR in the India-specific setting are being framed.
Okay.
And they will be applicable today. But as things will improve, those guidelines will also evolve to make TIR. I think ultimately it will be a standard thing, like you wear, those devices on your wrist that similar to your pulse and blood pressure. I think ultimately we'll all get used to measuring our glucose also if required. So at the moment, the guidelines for India are being framed. It has entered the guidelines for in American and European recommendations. But I do expect that even there, whatever guideline we make will also move progressively towards greater use as the years pass.
Right. So this actually brings me down to my last question as to what do you think is needed to make this more accessible and affordable? In a country like India, we have data that says 1 in every 6 Indians is suffering from diabetes. We have such a high risk population. Not everybody has access to healthcare. How do you think, or what is needed to make this more affordable and accessible to the mass population?
So I think, firstly, you have to understand, as you already actually said a little bit, that there are many Indias within Indias, right? There are people who don't have access to the basic drugs sometimes, don't have access to a qualified doctor. There are others who have access to the top doctors and can afford anything under the sun. So while our focus has to be at the bottom of the heap, there's no question. And we have very, very large numbers of people with diabetes, 77 million at least, if not more. I think they are much more actually. But we also have to cater to those who can have access to technology, right? So I think we have to balance it out. The way these things, firstly, we have to make sure that at least those in the urban setting, etc., who have access and who don't have, who are better off financially, at least there this becomes standard of care. So we should try and introduce for those patients who require it, of course, that in our practice, people on complex regimens understand the importance of continuous monitoring, and more people adopt it. And I think that will be the first step. The second step will be that as the pricing comes down and as people realize the value, as it enters government reimbursement systems, the use will go up hugely. It's a huge thing. So if it enters a reimbursement system, then the use will go up a lot. Remember, you can do many things with that. You can actually remotely monitor patients very distant. So if they have the device, they can share the data and you can actually help out people. So you're actually saving a lot of cost by avoiding their travel, by using telemedicine, simply because you've empowered the patient to do this.
Right.
So lots of angles are there, but I do think more and more simplification of technology, retaining or enhancing the accuracy. Obviously, I think volumes will drive the cost down ultimately, and acceptance by the government systems of the technology will ultimately lead to its use, with in most Indians. But at the moment, the first goal is to at least have those Indians, those of us, those patients who can afford it, at least they should understand and start using the technology as much as possible wherever it's indicated.
Right. I think that answers it all. This has been thoroughly insightful. And for those of you who are watching this, do try to understand the new technologies that are coming forth. Try to adopt them if you can and you have the access to them. And like Doctor said, telemedicine is the future of where we're going. So this would help both the patients, empower them in understanding their own health and managing it, and also give a holistic picture for doctors to better engage with treatment plans. Thank you, Dr. Mithal. It's been a pleasure talking to you today. And I hope our viewers gain a lot more information and be at the forefront of this. So thank you so much.
Thank you.